Hi there. So continuing on in our CPC review, in this video, we are going to go over the integumentary system and what you need to know to prepare you for the CPC exam. So under the skin, subcutaneous and accessory structure for the excision of lesions, benign or malignant, we want to make sure that you pay attention to the guidelines for these codes. Simple closure is going to be included in the procedure for the excision of a lesion, so you're not going to report that separately. You do report separately each lesion that is excised, though. Our codes are going to be based upon anatomic location and the size, lesions plus the margins. And for malignant lesions, append modifier 58 if the patient has a follow-up, re-excision, follow-up or re-excision during the post-operative period. So the excision of a lesion does involve full thickness removal of lesions from various anatomical sites. There are going to be extensive guidelines for both removal of benign and malignant lesions. Remember, benign is non-cancerous, malignant is cancerous. You have to pay attention to that in your choosing of your correct procedure code. For both types of lesions, a simple single layered closure is going to be included and not reported separately. If an intermediate or complex closure is required, the repair codes are separately reportable in addition to the lesion removal. So you would have the lesion removal plus a code for a complex or intermediate repair. And that is going to be determined in the documentation. Codes are also going to be selected on the anatomical location and the size of the lesion. The size is calculated prior to the excision by measuring the size of the lesion and adding in the size of the margins as well. And the reason they add on the margins is so they get enough tissue to allow them to excise the complete lesion. See the guidelines for examples of size calculations. Each lesion is going to be removed. Each lesion removed is separately reportable. Your malignant lesions have one additional instruction that is related to the additional required excisions on a different day during the post-op period. An additional lesion removal is going to be billed with a modifier 58 appended to indicate that it occurred during the post-operative period. If you did not include this modifier 58, the insurance would not pay this payment. They would say it is included as part of the post-op period. So the modifier is going to be extremely important in this case. So for a coding tip for the integumentary system, you want to underline the different anatomical options and then add notes to the page where you see the codes, such as code per lesion. You want to highlight or add a note there that it states that in the code descriptor. For your polynomial cyst, you want to code these according to the complexity of the excision, whether it's simple, extensive, or complicated. A polynomial cyst is a sac under the skin at the base of the spine that can become infected. When this happens, the physician will use a scalpel to excise all of the adjacent tissue. The services are reported according to the complexity of the excision. And again, that will be in our documentation. For wound repair, codes for wound repair closure is going to include sutures, staples, or tissue adhesive, which is your super glue for the skin. If only adhesive strips are used, the service is coded using an E&M or evaluation and management code or office visit. So 2 important guidelines to remember for your wound repair: measure and report the size in centimeters. And when there are multiple wounds that are repaired, add together the lengths of those that are in the same classification or repair type and same anatomic grouping. You do not add together lengths from different classifications. So if you have an intermediate and a complex repair, each one of those would be coded separately. If you had multiple intermediate repairs, I say 1 to the thigh, 1 to the foot, and 1 to the arm,
If the code descriptor shows all of those anatomical locations in that grouping, you would only code that particular code. And you would add the size of the wounds together to come up with that one code for that intermediate repair. The definitions for your types of wound repair are going to be found in your guidelines. Read them, highlight them. Read them, highlight them. So simple repair is a wound that is superficial and requires just a single layer closure. An intermediate repair, this is where the wound is going to be deeper and it requires a layered closure of one or more of the deeper layers of the subcutaneous tissue or the superficial fascia. It include limited undermining, so that's some limited cleaning out. It also includes a heavily contaminated wound that requires extensive cleaning or removal of particulate matter. And then a complex repair is going to be a wound that requires more than a layered closure, a scar revision, debridement, extensive undermining, stents, or even retention sutures. So this is going to be a pretty severe type of wound, probably due to some type of a traumatic injury. So in the preparation of your book, it's helpful to add notes to the wound repair section of codes as a reminder of the guideline, such as add together wounds by the repair type and anatomical group. It is also helpful to underline or highlight the different anatomical groups. For your adjacent tissue transfers, we want to make sure we're paying attention to the guidelines for these codes. These codes do not apply to direct closure or rearrangement of traumatic wounds. The excision of a benign or malignant lesion is not separately reportable with an adjacent tissue transfer when it is done for the same lesion. And then skin graft necessary to close a secondary defect is going to be separately reportable. Coding concepts for adjacent tissue transfer is going to include anatomical location and size. Adjacent tissue transfers are performed when wounds require more than just a simple, intermediate, or complex closure. Examples of an adjacent tissue include a Y-plasty or Z-plasty, advancement flaps, or rotation flaps. This is taking a full thickness portion of the skin and then rotating or advancing the skin into the defect. If a lesion is excised and the defect is closed with a flap, the excision is included in the flap reconstruction. A tip for you, tissue transferred from an area adjacent to the defect is known as a local flap. It may be described based on its shape, such as a V or Y flap, or as an advancement or pivotable flap. Tissue transferred from a non-contiguous anatomical site, a different part of the body, is going to be referred to as a distant flap. Your code selection is going to be based on the body area and size of the defect. The codes used here are divided into body areas and square centimeters. You can refer to your guidelines in your CPT manual to help you with that. But this is also going to be a good page to highlight or tab in your coding manual. Under repairs, this is going to be your skin replacement surgery and skin substitutes. For CPT codes 15002 to 15005, these are going to be based on the size of the repair and the site. For 15040 to 15261, these are going to be reported for autografts and tissue cultured autografts. 15271 to 278 is reported for your skin substitute grafts. CPT code 15050 is a pinch graft, and this is going to be measured in centimeters. All of your other skin graft codes are going to be determined by the size of the defect in square centimeters, and then square centimeters calculation is going to be length in centimeters times the width in centimeters. That's something you would mark. Something I would recommend you marking in your book as well is putting that formula down. Your skin replacement surgery and skin substitute section starts with codes for the surgical prep of the recipient site, The recipient is that who is receiving it, and are going to be based on the anatomical area and size of the wound preparation. Something to remember, these are very, very specialized codes. So this is going to be for a dermatologist or even maybe a breast surgeon or other type of surgeon who is doing these types of surgeries. So the harvest and placement of the skin graft, so this is where they're taking the skin graft and then placing it, is going to be reported based upon the type of graft. So is it a split thickness, full thickness, epidermal, etc.? Location, where is the graft going, not where it came from. And then size. Note, measurement is in square centimeters for adults and children 10 years of age and older. Patients less than 10 years of age is going to be measured by percentage. A tip, an autograft is a graft obtained from the patient, such as a split thickness or full thickness graft. An allograft is a graft obtained from another human donor, such as a cadaver. A xenograft is obtained from an animal, such as a pig, and your culture tissue is man-made skin substitutes created in a lab. For example, such as alloderm, aplograft, and integra. A split thickness skin graft includes a full layer of the epidermis, remember that's the top layer of skin, and part of the dermis. The full thickness skin graft will include a full layer of the epidermis and dermis, where split thickness and full thickness skin grafts are reported by square centimeters for adults and 1% of the body area of infants and children. Destructions under the integumentary system, ablation by any method other than excision. This includes electrosurgery, cryosurgery, laser treatment, and chemical treatment. For your benign and premalignant lesions, this is going to be based upon the number of lesions. For malignant lesions, it's going to be according to the location and size in centimeters. Again, another good place to put the note in your CPT book, right? It would be right here under ablations for the benign and the malignant lesions. Some other guidelines. We're going to look, it's going to, the coding concept for the destruction of the lesion is going to include the type of lesion. So benign, malignant, or premalignant, the anatomical location and size of the lesion, diameter, and then destruction of lesions can be performed by ablation, electrosurgery, cryosurgery, laser, chemical treatment, and surgical curtailment. There are occasions where the physician and patient will choose to have a skin cancer destroyed as opposed to excised. In this situation, it is important first to have the pathology report that indicates the lesion is malignant and also the location and size of the lesion prior to the destruction. A tip for you: when multiple lesions are destroyed, select a separate code for each lesion. For your Mohs microscopic surgery, with this surgery, the physician is acting as both the surgeon and the pathologist. So the surgeon treats complex or ill-defined skin cancers. In the Mohs surgery, there are two concepts to know: stages and blocks. A stage represents each deeper layer of the tissue that is removed, where a block represents the smaller section of each stage that will be prepared for examination under the microscope looking for the cancer. So the physician, they remove the tumor tissues and then perform a histopathological exam. And they do this and they keep removing the layers until they don't see any cancerous tissues anymore. Sometimes they'll do it, they'll have the patient wait a week or two, and then the patient will come back and they'll do a second, and that's part of the stages for the surgery. Just really, you have to pay attention to the documentation as well as the code descriptor for the Mohs microscopic surgery. So to report Mohs surgery, we need to know the anatomical location, the number of stages or layers of tissue removed, and the number of blocks per stage, or how many microscope-ready specimens were made from each stage of the tissue removed. So if they removed the first layer of tissue and they prepared 2 slides, it would be 1 stage, 2 blocks, and so forth. If they removed 2 layers, that would be 2 stages. And that, so I hope that makes sense. For our breast biopsies, and you did have a Mohs microscopic surgery question in your packet, your pre-packet questions, and so we will talk about that in just a few moments. Your breast biopsies, coding concepts for breast biopsy procedure include the approach and the with or without. Breast biopsies can be performed as percutaneous or open. For codes that include image guidance, the options are stereotactic, ultrasound, and magnetic resonance. Do not report imaging guidance separately because it is included in the code description. A code is reported for each lesion biopsy. Pay attention to your parenthetical instructions. So a tip for you: when a localization device is placed during a breast biopsy, you're going to report a code from CPT code 19081 through 19086. If imaging guidance is not performed, then you would report CPT code 19100. For your mastectomy codes, this is going to include complexity and with or without muscle removal. A partial mastectomy is described as a lumpectomy. Telectomy or quadrantectomy or segmentectomy. If the surgeon also removes axillary lymph nodes, both portions of the surgery are reported with a single code. The remaining mastectomy codes describe the extent of the surgery. Simple complete is the removal of just the breast. Radical includes the pectoral muscles and axillary lymph nodes. A radical mastectomy includes the breast pectoralis muscle and axillary and internal mammary lymph nodes or urban type. And a modified radical mastectomy includes axillary lymph nodes with or without pectoralis minor muscle, but excludes the pectoris major muscle. Probably did not realize there were so many different mastectomies. So your 19304, that's going to be the lumpectomy. All right, so let's talk about these questions here from your pre-packet. So question number 2 was a preoperative diagnosis of basal cell carcinoma. Postoperative diagnosis is the same. Patient had the Mohs microscopic surgeries. You see that's highlighted. We then see under indication, the patient has a biopsy-proven basal cell carcinoma on the nasal tip measuring 8 by 7 millimeters. Due to the location, Mohs surgery is indicated. Mohs surgical procedure was explained, including other therapeutic options and the inherent risk of bleeding, scar formation, reaction to local anesthesia, cosmetic deformity, recurrence infection, and nerve damage. Informed consent was obtained, and the patient underwent fresh tissue Mohs surgery as follows. So in stage 1, it states here that it was identified, the patient was placed supine, area was identified for excision was cleared, draped, and infiltrated with lidocaine and epinephrine. The area of the tumor and margins were marked for excision. Additional soft tissue markings were created to keep the specimen oriented with the excision site. So excision was highlighted to show that's what was done. Hemostasis was obtained with electrocautery. A pressure dressing was placed. The tissue was divided into 2 tissue blocks, which were mapped, color-coded with their margins and set to the technician on the tissue block. Following surgery, the defect measured 10 by 13 millimeters to the subcutaneous tissue. Closure will be done by Dr. Hill from plastics with a Burroughs graft. So we have Mohs microscopic surgery, basal cell carcinoma measuring 8.7, an excision of 2 tissue blocks under stage 1. So CPT code would have been 17311 for the stage 1 tissue and with the 2 blocks, and then C44.3 run 1 for the basal cell carcinoma on the nose. So here we see the rationale in that. So on the previous slide, so our 17311. So if we look at 17311, Mohs microscopic technique, including the removal of all gross tumor, surgical excision of tissues specimens mapping, color coding of specimens, microscopic examination, and histological preparation, including routine stains, head, neck, hands, feet, genitalia, or any location with surgery directly involving muscle, cartilage, bone, tendon, major nerve, or vessels. So it was on the nose, so that makes it the head and feet are under that. And then we have stage 1 up to 5 tissue blocks, and we know there was 2 tissue blocks. If there were additional, then we would have been able to use the 17312 and so forth. So making sure that you're paying attention to that. And then question 3, pre-op and post-op diagnosis, benign lesion of the right upper back. Operation performed, excision of a benign lesion on the right upper back. We have our indication. Description of the procedure. Patient was placed in the prone position on the table. No sedation was given. The area of the right upper back was prepped and draped in a sterile fashion with betadine paint. The area was located on the right upper back and had a maximum diameter of 1 centimeter. This had a 3 millimeter margin designed for a total resection of 1.6. It was infiltrated with 1% lidocaine with epinephrine. It was excised. The wound was irrigated. Hemostasis was achieved and then closed with 1 layer. So that says a simple closure, 1 layer with 5-0 prolene. The area was covered. Patient tolerated well. So 11402 would be for the excision of the benign lesion on the back with a simple closure, and D23.54 our diagnosis of benign lesion of the right upper back. So again, here we see just a breakdown of the guidelines when it comes to our excisions. So location, total size diameter, and then we have all of the codes there. And then question 4, diabetic foot ulcer. Right foot, diabetic ulcer, right great toe. So here we have 2 different, we have a diabetic foot ulcer on the right foot, and then we have a diabetic ulcer on the right great toe. Operation, subcutaneous right foot ulcer excisional debridement and subcutaneous right great toe excisional debridement. Under description of procedure, patient was taken to the operating suite, placed in supine position, gave an IV sedation. His right foot was prepped sterilely, sterile towels and drapes and applied. A Norison debriding scalpel is used to proceed with a partial thickness debridement of 12 square centimeters of the lateral aspect of the foot. So we got 12 square centimeters on lateral. Lateral is what? Just so remembering your term, lateral of the foot. Excuse me. We also utilize a 10-blade scalpel as necessary as well. All non-viable skin and subcutaneous tissue was debrided. This is on the lateral aspect of his foot. We then use a 10-blade scalpel for subcutaneous excisional debridement of 6 square centimeters of his right great toe ulcer as well. Pressure is applied for hemostasis, and then a pressure dressing is applied subsequently. The patient tolerated the procedure well and was transferred to the recovery room. So what is CPT and ICD-10? So our CPT is going to be 11042. And it's going to be added together because it's in the same anatomical location. They are both excisional debridements, and so we would add the 12 and the 6 square centimeters together. We then have diagnosis of E11.621, because we know it says up at the top that the patient is diabetic. And the 621 is going to be an indication of a condition because of the diabetes. And then we have the L97.411 and the L97.511 for the right foot ulcer and the right great toe ulcer, diabetic. So E11.621 is diabetic with foot ulcer. The 411 is for the foot, and the 511 is for the part of the right foot.
and midfoot. So we got the midfoot for the lateral aspect of the foot, and then the L51 is for the toe. And that is it for the integumentary system.